Yeah, well, thank you for inviting me to give this talk. It's something dear to my heart. As a geriatrician, I primarily work at long-term care and assisted living. And by the way, I'm a little hoarse, getting over a respiratory infection of some sort, and pretty much recovered, but left me with a little bit of a hoarse voice. So we'll do our best here. I got a glass of water just in case if needed. So let's see here. No conflicts of interest. So dementia. What is dementia? We're going to talk about the different categories of dementia, the characteristics of dementia, behavioral issues related to dementia, and that's one of the more challenging aspects of caring for folks with dementia. Some treatment perspectives of dementia continues to ever evolve, so we'll touch base on that a little bit. Particularly, we'll talk about caregiver-related issues with dementia. And then we'll also talk about some end-of-life care for patients with dementia. Some population projections. Our population is aging. Just a few years ago, there were a little over 55 million folks above the age of 65 in the United States. And last year, there were 62 million. That represents about 18% of the U.S. population. In roughly 20 or 15 years, it'll be 78 million or 22% of the population, or 1 in 5 Americans. The folks who are above the age of 85 in 2020, there were almost 7 million individuals above the age of 85. And again, 15 years, there'll be close to 15 million. The 85-year-old population is the fastest growing segment of our population, and it's been that way for many years. So again, our population is aging. And there are, quite a few folks that are above the age of 100. In 2024, they're estimated about 101,000 persons in the United States. And in 2054, roughly 30 years, there'll be more than 400,000 persons in the United States above the age of 100. What is dementia? I'm often asked, what is dementia? How does that compare to Alzheimer's disease? Dementia is an umbrella term applied to many disorders. And the newer term is neurocognitive disorder. In DSM-5, again, it's termed major neurocognitive disorder. In general, dementia refers to several disorders that cause significant decline in one or more areas of cognitive function, severe enough to result in functional decline. And that's the key, the functional decline aspect. It's not an inherent aspect of aging. It is different from normal cognitive lapses. All of us, especially as we age, we have those senior moments. Not unusual for a person to forget a person's name. That would probably be considered normal aging related, but dementia is much different than that. You don't remember that you don't remember type of thing. It's progressive and disabling. What is dementia? Again, it's acquired impairment of memory and other cognitive domains sufficient to affect daily life. Is caused by any disorder resulting in structural damage to brain systems involved in memory. And Alzheimer's disease, by far, is the most common disorder causing the dementia syndrome in later life. And the newer term is Alzheimer's disease without the apostrophe S. That a lot of our disorders have dropped that apostrophe S to take away that person does not have that disease per se. It's my understanding. So from here, I'll talk about Alzheimer's disease. There are types of dementia. This is kind of a busy slide, meant it to be busy. Alzheimer's disease is by far the most common form of dementia. It represents about 65% of all cases for dementia. There's vascular dementia, such as dementia that occurs after having a stroke, dementia Lewy bodies, Parkinson's disease for dementia with dementia. Those are very close kind of cousins to each other. It kind of depends what comes first, is the dementia or the Parkinson's symptoms. There's frontotemporal dementia. I'll see some of that, but that usually affects our younger individuals, those in our 60s and 70s. And my typical population is 80s and 90s that I care for. There's alcoholic dementia, post-hypoxic dementia, normal pressure hydrocephalus, metabolic dementia, thyroid or B12 deficiency, delirium. You have to rule that out, especially if it's acute onset, and depression. Last I read about, there's over 100 different diseases related to dementia. So it's ever involving and ever present. Reporting the diagnosis, fewer than half of people and their caregivers with Alzheimer's disease have been told of their diagnosis by their healthcare provider. Conveying the diagnosis can be associated with distress, but not definitively associated with increased suicidal risk. And healthcare professionals do have the professional, ethical, and sometimes legal obligation to disclose the diagnosis of dementia. And that can almost be the elephant in the room. Everybody knows that this is developing, and it's just good to kind of present it out front and give your recommendations and so forth. In terms of epidemiology of dementia, it's typically a disease that occurs later in life, generally beginning after the age of 65, though it can occur before the age of 65. When I was a fellow, I did my fellowship at University of Washington, and there was at that Alzheimer's Disease Research Center, it was the hub of Washington, and we'd even get folks from Alaska, and remember seeing a person in their late 30s who had dementia. Alzheimer's disease accounts for 2/3 of dementia cases, again, affecting 6 to 8% of older adults. And it's the most frequent cause of irreversible dementia in older adults. The prevalence doubles about every 5 years after the age of 60. So every 5 years, up to age 85, it's thought that almost a half of those folks who are in their mid-80s and above have some form of dementia. Vascular dementia is thought to cause an estimated 15 to 20% of cases and often coexist with Alzheimer's disease, and that's the mixed dementia. When I was at University of Washington, we did a lot of research, and that was typically the case. You'd see a little bit of this, a little bit of that, and it's not very oftentimes very clear cut on autopsy in terms of diagnosis. It's often a mixed picture. There's dementia with Lewy bodies that's increasing in prevalence and thought to be the second most common cause in people over the age of 65. In terms of statistics of dementia, I updated this from last year's talk. In 2024, again, almost 7 million people above the age of 65 have Alzheimer's disease, and it's projected to increase to almost 14 million by the age of 2060. Cost in the United States has significantly increased. About $1.3 trillion of our gross domestic product, or 1.5%, is spent on care for folks with dementia. In terms of projected prevalence of Alzheimer's disease, this slide presents it a little bit different way. The green bar are those folks age 65 to 74. The orange is those folks age 75 to 84, and the blue are those folks above the age of 85. So if you can see it, definitely progressing in all disease or all age categories, but definitely expanding exponentially in those above the age of 85. In terms of the impact of dementia, Medicare, Medicaid, private insurance provide much of the direct costs. The remaining costs are covered by families and their caregivers. In 2022, family care partners provide an estimated 18 billion hours of unpaid care. That's estimated cost nearly $339.5 billion, and that's the United States alone. Has a direct toll on patients, and nearly half of caregivers suffer psychological distress, especially depression, and have more physical health issues. And one statistic I read was 35% of caregivers of patients with dementia reported that their health had worsened due to care responsibilities, compared to 19% of those folks caring for someone else for some other issue besides dementia. So it does take a toll on everybody. In terms of etiology, it depends on what kind of protein or protein aggregate is it within the brain that sets off this cascade of events affecting neuronal function. In Alzheimer's disease, it's the amyloid plaques and your neurofibrillary tangles. So it's the plaques and tangles. And A beta is generally related to the amyloid plaques, and tau is related to the neurofibrillary tangles. In terms of Lewy body and Parkinson's disease, dementia, it's related to those cytoplasmic alpha-synuclein inclusion bodies, and in frontotemporal dementia, your tau or ubiquitin proteins. On the left is Dr. Alois Alzheimer. He was the first person to diagnose Alzheimer's disease. And on the right is Augusta Dieter. She lived between the ages of 1850 to 1906, and she developed dementia at actually quite an early age. She was in her later 40s, and she ended up having to be in an asylum because of this. So that you're talking, 120 years ago. Dr. Alzheimer kind of negotiated with Auguste's husband that he would pay for his asylum if he would be able to have access to her body basically after she died. And Dr. Alois Alzheimer's was a psychiatrist and neuropathologist, and he was the first person to do an autopsy on a person with dementia. And he was the first person that kind of identified the plaques and tangles in the brain. It didn't really become noted as a diagnosis, though, until 1910. 1910 was the first time that Alzheimer's disease was listed as a diagnosis. This is a coronal section of a CT scan. On the left is a normal brain. On the right is a person with Alzheimer's disease. As you can see, the ventricles are enlarged, the sulci are wide and deep. The hippocampi are pretty non-existent in folks with Alzheimer's disease. Hippocampi is, you could say, kind of the central processing for memory. And so that pretty much deteriorates significantly in a person with dementia. And this is a slide of the plaques and tangles. Plaques are the kind of the smudge print, thumbprint smudges there, and then the tangles are the kind of teardrop shaped lesions there. Alzheimer's disease, the diagnosis of Alzheimer's disease can be made on the basis of a typical presentation in the great majority of cases. It's an insidious onset of progressive memory and executive impairment in a clear state of consciousness in later life. That's usually Alzheimer's disease. If you had to guess, if you can rule out pretty much the other issues that we talked about earlier with this, stroke presentation or Parkinson's disease dementia, if a person presents with you with memory impairment, it's probably mostly at least some form of Alzheimer's disease. Alzheimer's disease is characterized by decline in memory and learning. There are other cognitive domains that are affected. Complex attention, the ability to multitask, executive function, that includes the ability to plan, organize, make decisions, ability to learn and or recall. And that's generally the hallmark of Alzheimer's disease. You have impairment in language or verbal fluency, expressive or receptive, and that include grammar or syntax, and perceptual motor control, understanding what one sees. If you put a hairbrush, hopefully in my hand, I would know what it is and what to do with it. But if you did that to someone with Alzheimer's disease, they would not know what to do with it per se. And it can affect social cognition as well, in terms of a person has less of a filter. That usually occurs in folks who have more advanced Alzheimer's disease. That's one of the hallmarks of frontotemporal dementia. And the other key is interference with activities of daily living due to the decline in these cognitive functions. So that functional impairment is the key. I often talk about the A's of Alzheimer's disease. Agnosia, again, the inability to interpret sensations and recognize items, kind of the hairbrush example again. Anomia, unable to recall the name of everyday objects. Aphasia, impaired expression and understanding of language. Apraxia, unable to perform purposeful actions. So it's not that they had a stroke and have paralysis of a limb, but there's a disconnect between the brain and that limb in a folks with dementia. And amnesia, memory loss. So those are your 5 A's. So it's kind of key to keep those in mind. Again, one of the more challenging aspects of folks with dementia are behavioral issues. So I just want to talk a little bit about that as well. And that's considered our ABCs: activities of daily living, behavior, and cognition. Behavioral disturbances related to dementia generally fall into three different groups: mood symptoms, psychosis, and specific behavior problems. Um, uh, can be polysymptomatic, and so if it is, one approach is to target treatment to that prevailing feature, such as treat psychoses, or maybe an antipsychotic, mood symptoms, maybe with an antidepressant. But a person can also, be aggressive or have behavioral disruption. In terms of signs and symptoms of Alzheimer's disease, generally it's classified in three different stages. You have your early stage, middle stage, and advanced stage. And as you can see here, generally memory loss, executive dysfunction, those A's again present throughout all the stages. Generally in your middle stage and advanced stage is when you have that more disruptive agitation and psychosis develop, at least in Alzheimer's disease. That can kind of set it off maybe from dementia or Lewy bodies, where sometimes those psychoses occur earlier in the disease process. In symptoms of dementia, as many as 80 to 90% of patients with dementia develop at least one distressing symptom over the course of their illness. Behavioral disturbances or psychotic symptoms in dementia often precipitate that nursing home placement, which often families dread about doing. Disturbances can be treatable, though it can be challenging, though it is vital to anticipate and recognize them early. Again, some other clinical features. Common behavioral and psychological symptoms of dementia include anxiety, apathy, depression, sleep disturbance, resistance to care, appetite changes, can have some irritability, wandering, verbal disruptions, other behavioral issues per se, and psychoses. Psychiatric symptoms may develop that resemble discrete mental disorders such as depression or even mania. Neuropsychiatric symptoms such as apathy, poor self-care, or paranoia may be the first indication of dementia. I'm sometimes called from a nurse regarding a person is agitated. And what does that mean? It can mean a whole host of different things. Generally reflects the loss of ability to modulate behavioral in a socially acceptable way. The term agitation is commonly used, but it's very nonspecific. And that's where I try to have the nurse to explain what is going on, what is the issue at hand. It's important to have a careful description of that nature of the symptom, when it occurs, where it develops, if there are any precipitants identified. Examples can include verbal outbursts, physical aggression, resistance to bathing, other care needs, restless motor activities such as pacing or rocking. Can occur concomitantly with other psychiatric or psychotic symptoms such as paranoia, delusions, or hallucinations. Overt resistance to care is most often seen, though, in those later stages of dementia, but it can be the first sign of incipient cognitive decline. There are definitely medical issues that may arise in a person with dementia. Disturbances that are new, acute in onset, or evolving rapidly are most often due to medical condition or medication toxicity. An isolated behavioral disturbance can be the sole or only presenting symptom. So it's important to rule out maybe that person does have a urinary tract infection. Maybe that person's constipated. Maybe that person has uncontrolled diabetes, glucose level is 500 plus. Maybe there was a new medication added. Maybe that's a side effect of a medication. Or maybe there's a basic need, such as maybe that person's hungry or thirsty. So those are all things that at least I think about when I hear a person being agitated. Other behavioral symptoms, again, frontotemporal dementia, often associated with prominent disinhibition, compulsive behavior, social impairment, and generally occurs at a younger age of onset. And it can include hyperphagia, hyperactivity, and even hypersexuality. Dementia or Lewy bodies, again, presents with that prominent psychosis, generally visual hallucinations. And for some reason, they often will see small people, children, or animals. In terms of behavioral symptoms, a person's feelings affect their behavior. A person with dementia may in fact feel lost, worried, anxious, vulnerable, helpless. Person may be aware that they are failing at tasks, especially in those early stages of dementia. and a person may feel that they are making fool of themselves. There can be definitely some triggers of catastrophic behavioral symptoms. Um, um, it's very difficult for a person to dementia to think of more than one thing at a time. So needing to think of several things at once can set off behavioral issues. Trying to do something that they can no longer manage. Being cared by someone who is rushed or upset. Not wanting to appear inadequate. Being hurried. Not understanding what they were asked to do. And not understanding what they saw or heard. So all of those can trigger behavioral issues. Other triggers include being tired, not feeling well. Persons with dementia, they obviously get respiratory infections themselves, and that can be a trigger. Not being able to make themselves understood, feeling frustrated, being treated like a child, and they just may feel overall just feeling sick and not knowing why. In terms of managing behavior, it was discussed in the 36-hour day. That's a very helpful resource. We'll talk about that in a moment. But the 6 hours of behavioral management include restriction. Have that person stop what they are doing, especially if that can harm themselves or others. Reassess. Consider a physical illness or medication may be a cause. Reconsider. Consider the point of view from the person with dementia. Rechannel. Consider safe and non-destructive avenue. Reassure. Mention the individual things are going to be okay. Just some reassurance can be very helpful. And after maybe that behavioral episode occurred, review, trying to think what just happened. Maybe you could approach it a different way next time. In terms of treatment perspectives of dementia, there are many resources for managing dementia. It's helpful to consider referral to a specialist. I'm a geriatrician. I see dementia daily, I would say. But maybe their primary care physician feels adequate to manage it as well. And that's a person that's often the quarterback in the management of caring for folks with dementia. A geriatric psychiatrist can be extremely helpful in helping to care for folks with dementia. Neurologists as well can be extremely helpful. Neuropsychologists can be helpful. That's generally probably early on in the disease course. A full battery neuropsychological testing can be quite lengthy and detailed, can take 3 to 4 hours. So generally, if I utilize that early on in the disease process. For folks with moderate to severe dementia, probably wouldn't be able to handle such a detailed test. A social worker, I get spoiled work in the nursing home. I have a social worker just down the hall. I can go ahead and say that, this is my concern per se. Same thing with therapy, physical therapy, occupational therapy, recreational therapy, mental health home care. Those are all folks that can be very helpful if a person's considered homebound with dementia. Nursing staff and pharmacists also can be very helpful. And there are, I think all of our hospital systems also now have memory disorder clinics. Here at St. Mary's, Dr. Kevin Foley is our director there. And we have St. Mary's was one of the first memory disorders clinic in town. So I utilize them occasionally as well, and they can be very helpful. Other resources for managing dementia, including that attorney for making a will, including someone to help with finances with conservatorship, estate planning, community, including neighbors and friends, aging and mental health networks, adult daycare, respite care, home health agency. There are organizations in town, including area agencies on aging, councils of aging, and other services also available, such as Meals on Wheels and senior citizen centers. Those are all ways that we can help folks with dementia here in Grand Rapids. This is a 36-hour day. This is a very helpful resource. It's been around for more than 40 years, and it's produced by a couple psychiatrists out of Johns Hopkins, and it's in its 7th edition. And I'm often relating this as a source for folks who are dealing with dementia, especially those caregivers or care partners. And it's in that seventh edition again. It comes out about every 4 to 5 years, so maybe close to having another edition come out. But keep that in mind if a person is asking for a good resource to read about. The tips in the book are tips that have been brought forth by family members and other caregivers dealing with dementia throughout the past several years. In terms of primary goal of treatment, it's important to manage dementia, especially those cognitive, behavioral, and psychosocial issues, enhance quality of life, and maximize functional performance by improving or stabilizing cognition, mood, and behavior, and recognizing acute changes and factors that can contribute to behavioral changes, especially interpersonal or emotional issues, as well as those acute medical illnesses. In terms of treatment, other treatment approaches, it's important to have caregiver education, support interventions to reduce distress and delay the need for nursing home placement. Behavioral disturbances may decrease with music, particularly during meals and bathing. And that strength of evidence was quite good with that. Light physical exercise or walking can be helpful. Address underlying precipitants related to medical conditions, including environment, caregiver, and basic needs. Use behavioral interventions and consider medications only if disturbances persist despite the best efforts at addressing above non-pharmacologically. Other non-pharmacological management tips include the cognitive training, generally for folks who have mild dementia, I would say. It can also include support of individual and group therapy, physical and mental activity, family and caregiver education support, safety monitoring, and oversight of your activities of daily living and instrumental activities of daily living. Maybe you may need some environmental modifications, supportive strategies such as clocks, calendars, to-do lists, keep handy visual cues, clues, simple and compassionate communication style, and structure activities to match that patient's ability. Other behavioral interventions include to evaluate and treat underlying medical conditions, assess for new medical problems, replace poor fitting hearing aids, eyeglasses, and dentures, make sure all those sensations are intact as best as possible. Maybe they have Struman impaction bilaterally, and I'm often removing that. And all of a sudden they can hear and maybe participate better in communication. Remove offending medications, particularly those medications that have high anticholinergic burden. Keep the environment comfortable, calm, home-like with use of familiar possessions. Reduce that aversive environmental stimuli. Provide regular daily activities and structure, and refer patients to adult care programs if needed. Other behavioral interventions include attend to that patient's sleep and eating pattern, install safety measures to prevent accidents, ensure that the caregiver or care partners has adequate respite, educate caregivers about practical aspects of dementia care and about behavioral disturbances, teach caregivers communication skills, how to avoid confrontation, techniques of ADL support, activities for dementia care, increase socialization with one-to-one visits. That was particularly an issue when we were earlier on in COVID, where the nursing home was locked down for more than a year. But fortunately, we're past that, so families can freely come visit. Maybe include that smartphone and tablet video communication with family and loved ones. The person with dementia obviously won't be able to do that themselves, but that's where maybe their nursing support can be helpful. That's one way that we were able to at least provide some family interaction when we were going through early days of COVID, to have family be able to see their loved one, at least by smartphone or, again, that tablet video communication. Behavioral intervention, important to simplify bathing and dressing. Helpful to say step by step what you're going to do, such as I'm going to take off your shirt now. Bathing is a rather complex process. We don't typically think it is, but it can be, especially with that person with dementia. Then if you can go step by step, they may be able to handle it better. Offer toileting frequently and anticipate incontinence as dementia progresses. Increase daytime activity level with physical exercise, ambulation, maybe dance, other movement activities. provide sensory enhancement and soothing interventions with pet therapy, hand massage, aromatherapy, again, music and art. Provide access to experienced professionals, again, in our community, including our geriatric care managers and recreational therapists. We'll touch briefly about pharmacological treatment. That's kind of a talk in of itself. There have been the cholinesterase inhibitors around for 35 years now. I think the original first one came out around 1990. They help a little bit. Memantine, again, for folks with the moderate to severe dementia. Kind of the whole wave of the future, though, are the use of the monoclonal antibodies. I think there are 3 on the market now. I don't personally use those, but folks in town are starting to utilize those. Antipsychotics, anxiolytics, mood stabilizers can all be helpful. There are other, again, pharmacological ways to treat folks with dementia, but for this talk, just primarily focusing on more caregiving-related issues with dementia. This is a slide or a video from Holland Home, and it talks about ways to assess a person with dementia, and I'll see if I can utilize this here. And it's about 7 minutes and long. I think you appreciate watching it.
Dementia is
It's embarrassing, overwhelmed,
hopeless,
frustrating.
angry.
Dementia is very pervasive. In Kent County alone, there are 100,000 people diagnosed with dementia. We were there the weekend that it kind of came to the forefront where she needed to be placed somewhere. We walked in the house, the stove was on, nothing in the pan, just burning.
This resident is going to be looking for her mother tonight. And she may not want to go to sleep until her mother comes in. So you need to reassure her that she'll be in and she'll come in and see her before she goes, when she gets in. If you can get her in bed, then she'll go to sleep.
We go at the same time and we sit at the same table and she orders the same food.
She taught me many things. She taught me how to stand up straight, to walk straight, to have good manners, to do all those things that grandmothers did with you, taught you to bake, taught you to do all those things, have the emotional connection. And that's what I really miss, because she could read my face and she knew me very well.
If you can get in front of him and say his name and actually get him to look into your eye and acknowledge that you're there, then he'll listen to you.
Active, bright people just lose the basic functions, sad.
To lose her physically was very difficult, but it was wonderful to be able to find myself in the picture book and know that, hey, she still loves me. I'm just in a picture. So the dementia journey creates empathy in a way where we can actually put on the senses of those who are going through dementia and enter their world in a way to teach us how to come alongside and be present with them where they need us to be. I don't know of anybody who would not benefit from going through an experience like this. We created our glasses and the inserts in the feet and our gloves. We bought our own headsets and we created iPods with the ambient noise.
Well, the dementia journey that I just went through, which simulates a real life situation, was unbelievable. It to have your eyesight diminished, your touch, your feel, your senses, your hearing. That's what these people, I'm sure, feel like every day.
I did not complete all the tests in the dementia journey.
My sight was restricted when I was going through the journey.
The most frustrating loss of sense for me was sight. When I looked in the closet, having to, move my head around, trying to figure out what sweater was what does a towel look like?
I was not able to fold clothes. The tactile stimulation, I couldn't feel my fingertips and where the towel was in relation to me.
Just doing simple tasks is frustrating. It's embarrassing. You can't find your way around. You don't remember the tasks in order. You don't know where to find the things you're supposed to be finding. And my touch was off with those gloves on. And obviously I couldn't even feel if I was writing correctly.
I had a cognizant mind and I had executive function intact when I went into the journey. And I felt like it was stripped away from me. And as I went from one task to the next, I felt like I need to succeed. I need to get all of these things done, and then I will be a success. And there was a real sense of loneliness. The Dementia Journey program is important in that it can teach our caregivers how to better serve the community of residents that we take care of.
So I realized when I'm approaching residents, I need to be coming at them from a forward position and getting down to their level so I can make eye contact.
I've learned through this experience that it's really important to put yourself in people's shoes. And for sure, those people who deal with this on a daily basis.
I read all the textbooks and I looked at all the case studies and the films, and I thought I had a really good understanding of what it was to care for someone or to have dementia. But really, you don't know what that's like until you actually care for someone with dementia. And then going through the dementia journey was really invaluable.
Moving forward, I think that, as much as I can try to make her environment feel comfortable and safe and make as few demands on her as possible, and just, joke around and have fun and love her, and don't put her in a situation that makes her too challenged.
The goal is to train every single staff member that works within Holland Home in the dementia journey. We have approximately 1,200 employees. That's a lot of people to get through a journey like this, but we want everybody that can come in contact with a patient or a resident to understand what dementia is about to the best of their ability.
And that may take follow-up from our educators to actually be on the units with them to help guide them and give them the confidence they need to say, okay, I can try this. I can do a different approach, and it actually works.
If I ever were to have dementia,
If you're going to take care of me,
I would say just keep it very simple.
approach me calmly and quietly and touch my hand to let me know that you're there.
Don't expect too much. Just joke with me
Just keep me safe and help me feel safe.
and just love me.
Let's see, can you hear me okay?
Yeah, we're good.
Okay, so yes, that's the dementia journey, and that all the new employees of Holland Home go through that. I actually went through it last year. It was pretty eye-opening to do those activities, and I remember someone commenting when I was doing this. New employee at Holland Home said, "Boy, I feel like I have dementia myself." And the folks over at Holland Home said if anybody ever wants to go through that, such as the fellows, they'd be happy to do that as well. So it takes about an hour or so. It's not very long. The whole process, they give a little bit of preemptive discussion, and then the actual journey itself is, I think, about 20 minutes or so. So let me know, and I can be happy to set that up for anybody as well. So the next slide is, this was a podcast that was done last year as well. Another great resource. This is called This Day and Age. And if you just Google this day and age, it's hosted by Phil Tower. Comes out about monthly. Been in process for the last couple of years, and this was a very interesting one that I listened to, and it talks about two different caregivers and their experiences on taking care for folks with dementia. In terms of defining caregiving, caregiving is the experience of providing physical and emotional care to another person. In the United States, caregiver refers to a person providing any type of care informally and without financial compensation. There's one kind of a new term, the Didactic Review Syllabus. That's another great resource. It comes out about every 3 years. It just came out actually this month, the new edition, version 12. And they wanted to kind of get away from caregiving more and talk about more of a care partner, kind of a reciprocal relationship between the person with disease and the person caring for that person with the disease. And people who provide care informally may not think of themselves as caregivers. Older adults receiving care may not identify themselves as care recipients, and they may be simultaneously providing care to another person. In terms of some statistics, 1 out of every 6 American adults provide care in a given year to someone above the age of 50. Half of them have no choice but to do so. And that most of the care giving is done by our ladies. Most of it is done by our older adult, but there are some folks who are younger, such as those in their 20s and 30s are actually doing some form of caregiving. Majority of all caregiving comes from our family members, 75 to 85% of all care. This is a new slide I wanted to introduce. Probably heard about this back in the press. Gene Hackman, he passed away last month, along with his wife, Betsy Arcara. Apparently, she was the caregiver for Gene Hackman. It was an interesting situation. I think details are still evolving, but apparently, Mr. Hackman had severe dementia. Betsy passed away. The autopsy report came out that she died of hantavirus pulmonary syndrome, and that she died. I think it was February 11. Or February 12, they believe, and then he passed away about 6 to 7 days later. So she was primarily a caregiver for him. So when she passed away from the hantavirus syndrome, there was nobody left to care for him, and then he eventually passed away a few days later, which is very sad. So obviously dementia affects even our famous folks. Caregiver statistics, 15% of caregivers support an unrelated individual. 28% of caregivers have been caring for folks more than the age of for more than 5 years. 18% of caregivers reported being highly strained financially, and about 25% of all caregivers had difficulty obtaining local affordable care services. Compared to 2015, there's a greater proportion of caregiver adults providing care to multiple people now, with 24% caring for 2 or more recipients. Employment status varies widely among caregivers regardless of age, and caregivers do not always disclose their role to supervisors and commonly rely on flexible work hours. Some caregiving general suggestions, keep the caregiver informed, share your concerns with the person with dementia, especially if that disease may be mild. Other caregiving tips for the caregivers: try to solve your most frustrating problems one at a time. Make sure the caregiver gets enough rest themselves. Use common sense and imagination, and maintain a sense of humor. Even for folks with severe dementia, can still engage in some humor. Additional caregiving tips: try to establish an environment that allows as much freedom as possible, but also offers the structure that people with dementia need. Remember to talk to the person directly. Have an ID bracelet made for the person who has dementia, and consider a possible wearable tracking device. Keep the person active, but not overdo it, not get that person upset. Again, caregivers report physical, emotional, and financial strain. And often they can feel alone, the caregiver does. When compared to 2015, again, caregivers report their health status, fewer caregivers report their health status as excellent or very good, and this has actually decreased compared to a few years ago. And more are reporting their health to be fair or poor. In terms of assessment of caregivers, caregivers often benefit from conversations that simultaneously screen for distress and assess their needs. Ask the caregiver, do you provide care to another adult loved one? Who are they caring for? Ask the caregiver, do you feel strained when you're around your loved one? Do you feel you have lost control of your life since you started providing care for your loved one? And how burdened do you feel caring for your loved one? Last few slides focus on some options for caregiving. In the community, again, we have those community resources, area agencies, and aging. And this helps to coordinate services to maintain older adult and folks with disabilities in their home for as long as possible. They participate in advocacy, conduct needs assessment, coordinate plans and services to address these needs. One thing to keep in mind, though, is when does that person need to move to a higher level of care? Why and when is it best for that person to move? There are several nursing homes available in town, and fortunately, I work for some of the best. One of the best resources includes the www.medicare.gov nursing home compare website. It's based on a 5-star system, and that's where folks can go in to see, how much, how good are those different nursing homes. In terms of other considerations, consider, how will this placement affect the person's life? Also, the cost of long-term care. Other types of living arrangements, you can provide full-time support in home, but that's very expensive. 24/7 in the home is actually much more expensive than in nursing home, and nursing home care it's itself very expensive these days. A good option may be adult foster home or group home. We have our PACE program here in town. Continuing Care Retirement Community, CCRC, Holland Home, where I work, was the first continuing care retirement community in Michigan, and services several people. Assisted living or residential care facility may be a good option. Some of our assisted living units specialize in dementia unit and in dementia care, such as at Raybrook. There's about 4 different specific dementia units in assisted living at Raybrook Manor of Holland Home. And again, nursing facility. In terms of assisted living facility, they can be categorized or marketed under different titles. Some are characterized by, what kind of level of coordination or provision of care services they are providing, social activities, health-related services, primarily provide supervision in a home-like atmosphere to maximize autonomy and privacy. Care and assisted living generally is transitional. Average length of residency is about 2 years. Most folks in assisted living, though, eventually will need to be discharged to nursing home. There's different services are provided in assisted living. Housekeeping obviously is provided, meals, assistance with your activities of daily living, particularly with medication management. Some provide support to individuals with cognitive impairment or dementia. And each of these individual services may be provided, but sometimes they are needed at additional cost. Costs for assisted living residences vary greatly. Generally, it's out-of-pocket expense. Average cost in United States is per month is over $5,000 for assisted living. Average cost for nursing home is twice that, so about $10,000 to $11,000 per month. So if you have a person in the nursing home for a year, that adds up quickly, right? Some long-term care insurance programs will cover cost, so that's something to keep in mind. Certain services are provided under social services block grant programs. They're not covered by Medicare. Some states may reimburse or plan to reimburse for assisted living services under Medicaid. And then finally, the continuing care retirement community. There are different models out there: all-inclusive, fee-for-service, modified coverage. Most require an entry fee plus a variable monthly fee. Funding for care in the nursing home, though, is largely private. Some facilities, again, will have those Medicare, Medicaid funded beds for skilled care. Then finally, end-of-life care for folks with dementia. It's important to keep some metrics in mind. Continue those discussions, especially regarding coordination of care. Try to manage hospitalization. If a person's going back and forth to the hospital several times with severe dementia, maybe we're looking at plans for comfort and with admission to hospice. It's important to try to recognize those end-of-life signs, providing supportive care, effective working relationship with the primary care team, failing staff and ongoing care, ongoing learning, and then continuing care after death. And the last slide is talks about who qualifies for hospice. Again, that's a whole talk of itself. That was developed greatly earlier this year. But keep in mind that those folks who are, functional assessment stage 7 or worse, when they're dependent on their activities of daily living, unable to walk, dress, bathe without assistance, unable to communicate, speaking less than 6 meaningful words per day. Those folks may be, be able to be qualified for hospice care. And keep in mind some of those medical complications that may also admit a person to hospice for comfort care. The last video, I think you enjoy as well. It's not as long, it's about a minute long or so.
Here's to the caregivers, to the caretakers, the cooks, the cleaners, the movers, and shakers. To the listeners and learners of the heart and the mind. To the teachers of patience and preachers of kind. To friends and loved ones, the sons and daughters, and to all of those who do unto others. Here's to the leaders, the compassionate, the caring, for the meaningful moments and every moment you're sharing. To the more than 14 million Americans caring for and caring about someone living with dementia. Thank you.
All right. Happy to entertain any questions or comments.
Thank you, Rob. This has been great. Always informative. You can go ahead and stop screen share because I'm going to actually throw something up in just a moment. We got a couple of comments and a question that came through the chat box. Two really quick comments. You notice that you commented that you work for some of the best nursing homes. I just want to put a plug in that one of the reasons that they're some of the best nursing homes is because of the work that you and your team invest in them, and the physician support that we have here in Grand Rapids for elder care is exceptional. And we're a unique community. I do some work around the country in terms of consulting and things of that sort, and we've got special things going on here in Grand Rapids, and it's the geriatricians like Rob and his group and others in town with the other systems that have really helped to create that culture there. Also, you had mentioned the Gene Hackman's death, and what that really underscores is the absolute life-saving critical role that the care partners provide. I mean, you take away the care partner and this, he's been within a week. I mean, what a huge responsibility. And many of the care partners don't even realize how important and critical that role is. And I think that the people that support them in the healthcare system may not be as well.
Yeah, with Mr. Hackman, it was the autopsy showed that she died of Hunter pulmonary syndrome, and he did not. His autopsy, I don't think I mentioned that, showed extensive hypertensive heart disease and atherosclerosis, along with advanced and severe dementia, Alzheimer's disease, actually.
Yeah, so he's not getting fed and he's not getting his free meds.
Right, right. And so even
Yeah.
though I'm sure they had all the resource, money to get additional resources, but they obviously were not set up ideally, right? So kind of a sad situation.
So another question I had right at the very beginning, you noticed you popped up a number that our centenarians are going to quadruple within the next couple of decades or 3 decades. And it's curious to me why we would do that with our life expectancy stagnant. What is it that's going to allow? I mean, is our healthcare system getting better? Are our older people getting healthier? How's that going to go from 100,000 to 400,000, given the nature of our healthcare system as it exists today?
Great question. I don't know if I have a good answer.
I recognize it's probably more rhetorical than anything else, but it struck me. And one other quick, the question that popped up in the chat, and I like this one too. Neurologists, in particular, seem to be maybe I should ask you, Joel. Neurologists seem to be very hesitant to diagnose dementia of any type unless they have full neuropsych testing profile, and even then seem to prefer the diagnosis of MCI. When can we, the other doctors in the room, feel comfortable making the diagnosis ourselves?
Great question. Well, first of all, neurologists like to categorize everything. So I think that's a lot of it is we want to go beyond just the blanket of Alzheimer's or the blanket of dementia. And I think that just speaks to being a neurologist and the personality. So I think that's part of it. MCI usually is that first diagnosis that anybody can make on neuropsych testing. Many people with MCI will just stay at MCI, but there's a certain percentage that if you test them again later on, will go on to develop some sort of dementia. So often it's that testing may be done too early that we can only give an MCI. So you retest a year later, 2 years later, you may have a better diagnosis. But I like what Rob said about functional decline. I mean, if you think about it, dementia really can be a clinical diagnosis without the full sort of workup. If you're seeing this slow progressive cognitive decline over years, and you've got that functional decline that goes with it, I mean, that by definition, you have a dementia. The next question really is how specific do you want to get with that diagnosis? Because a neurologist will get specific, but that's really only going to help you for a couple of years. After 2 or 3 years,
it's pretty academic.
It's pretty academic because dementia is dementia. It's all going to kind of end up the same way where you're dependent in your ADLs. You can't do your IADLs. You need a caregiver. You need to move into skilled nursing for safety reasons. So it does become an academic sort of thing.
And just a really minor self-deprecating thing. I was giving a lecture on dementia years ago at NHPCO, and I'm going through the slides. We're talking about this, and I get to the MCI thing, and someone said, "What's MCI?" I couldn't remember, and which brought a chuckle from the group. So anyway, okay. Other questions, comments for Rob from the floor here.
I had a question, Dr. Riekse. That dementia rates were rising in every age group. Is that proportional to the population increase, or do they think something's causing increased rates, or are people just being tested more often or more frequently or earlier?
I think a little bit of both, I would say. I think we're all becoming more aware of it compared to, a few decades ago. So I think that's one aspect of it, that maybe we're able to define it and diagnose it better than we did 20, 30 years ago. So that would be one aspect of it. Our population is aging. The number one risk factor for developing dementia is age. So as our population ages, we're obviously going to be seeing more folks with dementia. So, yeah.
When is it a good time to try those antibody treatments?
Yeah, great question. Usually early in the disease process is my understanding. They're very expensive, and I don't know if maybe Joel can provide a little bit more insight on it as well. You're talking several $1,000s. I think Leqembi is like $26,000 a year. And they're all infusions. And you have to do extensive MRI scans. It's only set up in more research stage centers right now. And so sometimes you can develop some bleeding. There's ARIA,
That's right.
ARIA, I think abnormal bleeding issues that occur in folks with that are on the monoclonal antibodies. That's the first time in like 20 years we've had something new for dementia. So sure, it is removing amyloid from the brain, but how significant is that? And I think I just have had one person that had it, the monoclonal antibody, and unfortunately she had a side effect to the treatment. So N of 1 is not a good so far. But have you had much interaction with that, Joel?
So just in the last year, we started doing Leqembi. So that is up and running at St. Mary's now. But I think to your point, Rob, you're absolutely right. We have ways of removing the tau, but we don't know what that's doing clinically. So a lot of these got FDA approved because we're removing the tau. We're getting rid of the proteins, but we don't really know what that means yet. And by the time you're seeing it on like MRI or you're finding it on imaging, you're really kind of at a stage where you're probably past that critical moment. And a lot of the research is saying we should be working years or decades upstream to kind of keep things at bay before they even get to that point where we need to remove it. So I think a lot more research needs to be done, and a lot more will come out in the next decade or so as far as how to best use these meds.
Well, I think it brings us back to our specialty. I mean, our job is we'll be taking care of these people who are getting these treatments that may or may not be providing any tangible clinical benefit to them. They still have needs. They still need the caregiving support. They still need palliative resources and a palliative plan of care in place, whether they're receiving it or not. And so I think that maintaining engagement at an early lecture, at an early stage is huge. Well, thanks again, Rob. Great lecture. Appreciate your time and
sure.
expertise.
Thank you.